Yeah, thank you, Natalia, for the invitation, and thank you, Lucas, for the great perspective from physician about the adaptation. So now let's move to the second part. On safety first, so we'll talk about safety. So the three major components of MR system are the main magnetic system, the grading system, and the RF system. And for each of the system, there are some potential hazard that's we need to be taken into consideration. Firstly, the MR scanner is operated with very high magnetic field. So when a ferromagnetic object is placed in the field, there will be strong translational and rotational force. So if the object is close to the magnet, it can be pulled into the bore and cause a projectile injury or damage the imaging equipment. And secondly, the MR scanner uses a grading coil to generate spatially varying magnetic field to encode the signal. And during the encoding process, the magnetic field will be switched rapidly and numerical time to encode the entire K space. And this rapid switching will induce eddy current in the nearby conductors and may cause heating, potential damage of implant device, and induce patient neurostimulation. Although the stimulation is more like for the 3 Tesla or higher, we don't really feel it's a concern for the MRIdian MR Linac. Lastly, the switching of the grading coil current will also cause the coil to physically vibrate and generate loud noise that may cause the acoustic injury. So hearing protection is very important. Lastly, there's also RF coil that's used to generate a time-varying electromagnetic field to excite the tissue and detect the signal. And this EM field will deposit energy into the patient tissue. So for implant device, jewelry, or anything with conducting material, it will induce localized heating. Therefore, to prevent MR safety-related incident, the patient screening is paramount. So the screening usually begins with consultation. During the consultation, if a patient is identified that may benefit from treating on the MRIdian system, then they will be screened to see if there are any contraindication to be treated on the system. And before the simulation, one of our team members will carefully review the chart, call the patient, and carefully go over the screening form. And then the patient will fill in this formal screening form before their simulation. During each treatment, therapists will conduct abbreviated screening and identify whether there's any change after their initial screening. And lastly, each time before the patient enters into the vault, therapists will use this magnetic, the metal detector to physically wind the patient to make sure there's no metal in the patient. Okay, moving to the simulation, patient will be scanned on both the view system as well as CT. So for the view simulation, they are usually positioned with arm down position to improve the patient comfort because the relatively long treatment for the adaptive case. And the UV contrast, which is MR safe gadolinium-based contrast agent, is available to improve the tumor visualization. During the simulation, there will be lightweight receiver coils placed under and over the patient body to receive the MR signal. Usually, the simulation is done without a wet bag because, as Lucas mentioned earlier, and for the small day-to-day variation, that will be taken care of by the adaptation. During the simulation, we will acquire 2 sets of images. One is the 3D volumetric image used for planning, shown on the left. And this is typically acquired when patient is doing inhale breath hold. So we ask the patient to do a comfortable inhale breath hold. The scan is again acquired with true phase sequence, which is a mix of T2 and T1 contrast. We also acquire a 2D cine image shown on the right, which is at the 4 frames per second. And this is to help us to assessing the breathing motion and evaluate the tracking performance. In addition to MR simulation, we also bring patient to CT to acquire a CT scan with matched position for electron density information. So there's some discussion about getting rid of CT scan for some patient, but at the moment, it's still our practice to acquire CT for the electron density. On the bottom is a figure I borrowed from Daniel showing the bore size comparison from MRIdian and our GE-CT scanner. So the MRIdian, the bore size larger than regular MR, but still smaller than the CT scanner. So the patient size is definitely a consideration when we put patient on the system. Okay, moving to the treatment planning, we will first deform the simulation CT to the simulation MR to get electron density information for the planning. So here's a video showing the deformation between the two, because usually they are acquired the same day, back to back with the same position. The system usually do a good job in aligning those two. But sometimes there will be some changes in the air water pockets that will require manual correction of the density. Then we will do the contouring. It can be either done in the viewer TPS or done in other external like MIM or Eclipse, and then transfer to the system. And I want to highlight some differences compared to regular like LINAC plan. First is that for the adaptive case, we'll always create a dose shell structure, which is a 2 cm expansion of your target shown on the yellow contour. So this is to improve the efficiency, because during adaptation, time is definitely an important factor. So for structure that with Dmax type of constraint, like the bowels, stomach, we will mainly focus on updating the contour within this dose shell for efficiency. So we will still contour the structure for the reasonable volume during initial planning, but during the adaptation, we will only mainly focus on within this dose shell, because there's nature dose fall off, so structure outside this shell usually won't be a concern. Secondly, we'll also save all our operations to generate the tuning structure as a rule. This also include like the expansion of GTV to PDV and all your like the PRV generation or all your tuning structure. During adaptation, after we clean up the contour, we can simply apply those to reproduce the structure. So by doing this beforehand, help us to save time during adaptation and reduce the possibility of errors. Another difference is that we will have electron density override structure in case there's an anatomical change during treatment, so we can use those structure to do manual electron density correction. And lastly, we will also create two empty structure. This is mainly due to limitation of the current system, where you cannot add structure on the fly during adaptation. So we created some empty structure beforehand in case we need that for different purpose. In terms of the beam arrangement, the current system only supports step and shoot fixed beam MRT. So usually we'll set up plan with over 20 beam angles to mimic the VMAC delivery. And we'll set up about 60 to 150 segment, depending on the anatomy. We might use higher segment if it's more complex plan, but this segment scale with the treatment time. One thing to point out is that the beam, they are not uniformly distributed. So we intentionally avoid beam going through the arm or going through the edge. So that's why you see the gap in the beam angle. So the reason of avoiding arm is to minimize the unnecessary dose to the arm, unless we really need those angle for dosimetry. For the couch edge, it's because for regular neck we use the carbon fiber, which is not has minimum transmission, minimum like attenuation, but for the this carbon fiber couch is electric conductive and may cause heating or image artifact. Therefore, viewer couch is made of different material, which is more dense and will attenuate about 15% of beam. So the beam going through the edge are not very robust, because depending on your day-to-day shift and setup, the beam that goes through the couch on one day may completely not go through the couch the other day. So to improve the plan robustness, we intentionally avoid the beam going through the edge of the couch. Here's a video showing the planning process. We will set up the electron density using our density table and set up all the override structure that we might need, and then set up our parameters such as the segment, the pixel size for your dose calculation, the efficiency, the parameter for the Monte Carlo calculation, and what's your dose resolution. On the bottom left, the tiny part, tiny window is where the dosimetrist will set up all your objective to get a good plan. And the system show you the plan RX comparison, so you can set up your constraints. If the plan doesn't meet the constraint, it will be highlighted in yellow. And you can view your plan in the 3 different views, adjust how you want to display the ISO dose line. You can turn on or off or change the display. One thing I like to highlight is it also tell you what's the estimated delivery time. So let me change to the winter. So here it shows you what's estimated delivery time. This including the movement of gantry and MLC and also the beam mount time. So for a case with repeated breath hold during treatment, we usually want to keep this as low as possible, say 12 minutes ideally, but sometimes because of complexity, it might be higher. One thing unique to the MRIdian system is the impact of the magnetic field on the dose distribution. So the electrons, the photon will generate electron, and the electron will experience the Lorentz force in the magnetic field and change their trajectory. Therefore, we need Monte Carlo algorithm to account for this impact. Here on the bottom is a figure showing a Monte Carlo simulation of the dose kernel at different field strengths. So at the field strength increase, you can see a drastic scale of the dose kernel toward the surface. So it will be a more severe concern for a higher field strength. And this change of the trajectory will also cause the hot spot or cold spot at the interface between high and the low density region. We call this the electron return effect. So here's a figure showing APPA type of plan calculated without magnetic effect of the magnetic field on the left and with the magnetic field on. So you can see because of the magnetic field, the skin will have higher exit dose if you consider the impact of the magnetic field. Okay, that's all about planning. So now let's move to the treatment. Here the flow chart showing the workflow for adaptive treatment. So each step is color-coded based on who is the primary person conducting the task. And as you can see, this is a relatively complicated process, requires close teamwork. So I'll go over some of the key steps. After patient is set up on the couch, we'll first acquire low-resolution, large field of view scan, which take about 15 seconds, and we'll roughly align patients based on this scan. We'll also verify that the beam will not entering through the arm after all the shift, so try to minimize the dose to the arm if possible. And for the alignment, we'll align to the spine first, and then verify the breath hold level, and then make adjustment based on our target. Then we'll acquire a high resolution scan for the fine alignment. This scan protocol is the same protocol as the planning MRI, so it's essentially MR fusion of the same MR protocol. MD will verify the positioning of the daily setup. So as Lucas mentioned, like the couch can only apply 3D correction, but any day-to-day like slight change can be accounted by doing the adaptation. So if adaptation is seemed to be deemed necessary, we'll then enter this contour interface, where DOSI and MD will update the structure contour based on the daily anatomy. Again, for the GI structure, we'll mainly focus on updating contours within this dose shell for efficiency. But for structure that has volumetric constraints, such as liver and kidney, so entire volume will be updated. Then we'll apply the rule to update all the PTV and the tuning structures. Then the physician will define which structure they want to track during the treatment. So this is a unique step for the view rate treatment. So we're really tracking the internal, the target or organ that you want to visualize. It's more like soft tissue-based tracking. The tracking structure should be defined on a single sagittal slice because the system can only image only support the real-time imaging on a single sagittal slice. And then the structure can be either your GTV or surrogate structure with clear contrast differences. So you can, if the, for example, GTV is too small or doesn't have good contrast difference, you can also use some organ or structure nearby it as your tracking surrogate. And if you're uncertain, you can also define multiple tracking structure in case one doesn't work. Then physicists will look at the electron density map and do the manual correction if needed. So this electron density map is generated by deforming your original electron density you get from the initial planning, and then deform it based on the deformation field between daily MR and your simulation MR. So it's a deformed electron density map. And this electron density, I would say, is one of the steps can be problematic. Here's a video. Let me switch to printer. And in this video, we use different MR protocol between the simulation and the treatment. So the simulation is a larger field of view, but the treatment, we use the shorter field of view, which actually gave us better image quality. So the alignment is good for the target region, but slightly off for the spine. And those two factors combined, you see the default, the electron density has some trouble in correctly deforming the spine region. So you will see some like curvature, which is not true. So therefore, like just highlighting the importance of carefully checking the electron density, because that's the key information used for your plan calculation. Okay, moving on, and then we will work on the planning process, and we can use the objective set up during the planning, and then recalculate, and then do the optimization. So once completed, we can review the plan, decide which one to treat. So on the left is in the bottom left figure. So the left one is a typical this one is a predicted plan, which is the plan you made during the planning, but predicts on the new anatomy. And on the right shows the re-optimized plan, which is a completely new plan you generated based on the today's anatomy. And you can compare the dose distribution, the plan objective shown on the right. It will highlight whether the constraints matter or not, and also compare the DVH and then decide which one you like to treat. So here's another example. Left is the original plan. On the right is a optimized new plan on the new anatomy. So the new plan met all the constraints, and then we are happy to proceed. But then our MD found out, wait a minute. So what's this bulging of this isodose line? This orange line is 100% isodose line. It's actually extend out of the PTV. So we carefully review the plan and realize one of the tuning structure was not updated appropriately. So there's dose is not very effective in pushing because the changing of the anatomy. So there's dose spill out. So we went back to correct the tuning structure and get a decent plan. So this highlights the importance of careful plan review under the time pressure, and the importance of having a robust plan and having all the rules, tuning structures set up appropriately during the planning. So moving on, if we decided to go with the new plan, then we will run the QA, but apparently we cannot take the patient out of the couch, set up the phantom. So our QA is based on a program that will recalculate the plan using a different algorithm. So it's kind of like independent comparison. So it will compare the dose calculating using the TBS, also the dose calculated with the another dose calculation model. And then we compare this to it to evaluate the gamma passing rate, dose difference, and some contour statistics. And one thing to note is that we also pay a lot of attention to the change of MU, because we don't want to see that the system now needs much more or much less of MU to deliver the same dose. So if there's a big change of MU, that can be indication of a suboptimal plan or potential error. So if the change is over than 15%, physicists will do a more in-depth offline review and justify whether the change makes sense before we move on. So here I show two cases where actually the error is caught by looking at this MU change. The top one is a case where the skin was accidentally deleted, and that affects electron density. So basically we are missing a lot of electron density information, and the adaptive plan now have much less MU to deliver the same dose. On the bottom one is a case where the MU doubled during adaptation, and apparently we don't feel comfortable, like right now we need double the MU to deliver the same dose, although there's some change of the anatomy. So after a deep dive, we found that objective function was not very appropriate. So it caused some confusion of the system, and it pushed very hard to meet some constraint and generated a lot of small segments. So we change our objective function to be more robust, and the new plan is having close MU with the original plan. So lastly, after the QA, making sure that's a good plan that we want to deliver, we'll set up the gating parameter. There are several things we'll define in the step, including which structure we want to track. That's the slide the physician just drew on the sagittal slides. And secondly, what's the tracking boundary that the structure need to stay in. This tracking boundary can be a numerical margin of your tracking structure or predefined contour like your PTB. And lastly, we'll define how much percentage is allowed to be outside of the tracking boundary. Typically, we say 5%, but also you can make it tighter. If you do 0%, that means your tracking structure need always be in your boundary. So the final step is to verify the tracking performance. We want to make sure the system generates a good tracking contour. So the contour should really follow the anatomy motion instead of just some random movement. So there are different tracking algorithms we can select from. The system also gives us a tracking confidence level, which is how confident the system feel about its tracking. So we generally want to making sure it's 80% confident about its tracking performance. And now everything's set and we are ready to beam on. But that's just the beginning of the treatment. During the treatment, our therapists will continue monitoring the patient with the cine MRI. They'll make sure the tracking contour really follows the true anatomy, and making sure the patient, their breathing pattern doesn't change, and they doesn't move. And one thing I want to highlight, we have the PDC system where the patient, they can actually see a screen show the image like on the right, so they can see their breathing pattern and they can adjust their breathing on the fly to improve the efficiency. So now we have our last question. Which one is true for adaptive planning? A is the entire GI structure need be updated. B is electron density should be checked, updated daily. C is GTV should be always utilized as a tracking structure. D is the plan QA should be done on the ARC track to verify it's a good plan prior to your BMA. Okay, so more than 50% people get it right. So the answer is B. We do need to check electron density, making sure it's correct based on the daily anatomy. So for the A, during the initial plan, you want to make sure you contour out the bulb structure well, but during adaptation, you really want to improve the efficiency. You do want to spend like 2 hours in just contouring. So it's more focused on region close to the target. For C, you can use GTV or surrogate structure if GTV is too small or hard to see. And D, you can do QA measurement-based QA afterward, but when the patient is on the couch, you do adaptation, you really cannot take the patient out to board and just set up your phantom. So lastly, a brief summary. So adaptive RT requires close teamwork as we really squeeze the typical 1 week of planning into 1 hour. So robust planning is important, and we need to set up the redundancy check to make sure all the critical steps are performed. So that's why we created this adaptive checklist shown on the right. So for all the critical steps, it will be sent out by 2 different people to make sure all the steps are appropriately performed. So after our people is signed, it will turn on green, and then we are okay to beam out. So that's all I have. Yeah, happy to take any question. Let me stop sharing.
Thank you so much, both of you. Excellent presentation. And I see Lucas changed his name to Cyrillic. Thank you, Lucas, for support. I have a question about SMART trial results for pancreas cancer patients. It's very impressive to see this such a high 1-year overall survival, 65%. What is it comparing to our treatment, let's say, on TrueBeam with 40 gray that we can deliver safely to pancreas cancer patients?
Yeah, good question. We don't have a great comparator arm. As far as I know, the other like kind of large prospective trials, there's some looking at 33 gray. And then most of those were also done in an era prior to FOLFIRINOX, so different chemotherapy. So it was like much lower survival. So it's a bit hard to tease it out in an era of more effective chemotherapy as well. But I think most people would have kind of guessed it to be like less than 40% with just kind of like taking it to 33 or 40 gray. But there was a randomized trial plan that we were starting to open here, looking at patients that could finish like 4 months of chemotherapy and then randomizing them to just getting more chemo or getting the SMART style of radiation with 50 gray, because the last trial there's not good randomized data for SABRE. There's for fractionated radiation where it actually didn't improve survival compared to just giving chemo alone. It improved local control, but not survival. So this was a trial that's powered to test for overall survival. We're very excited to enroll patients in it and get a more definitive answer. But again, now with the company no longer existing, that's not going to happen. We're hopeful that there can be a randomized trial going forward.
Maybe with Electa, possibly.
Yeah, potentially. I think now I saw that they also have some motion management solutions.
Right. They just released it.
Yeah. I think that was the main thing missing from their software. So yeah, hopefully.
Yeah. Thank you. So, but that's impressive. 40% versus 65%. That's really good gain.
Yeah.
It's too bad that MRIdian bankrupted. Any questions? I'm opening the floor for questions.
Hi, Yu. I have a question about delivering. Yeah, really nice presentation. Yeah, my question is, I noticed the delivery of the MR-Linac is not efficient because it's a step and shoot stick MRT. And I'm wondering why why not applying the VMAT to the MR-Linac for the dynamic beam is because of technical difficulty or the other consideration because of the MR?
Yeah, that's a good question. We all like VMAT, it's so efficient. The reading is more like technical issue because you are combining MR and RT, and these two parts essentially they don't like each other. So the MR will have the magnetic field will affect the linear accelerator, and the RT will also component will also interfere with the MR imaging acquisition. So the system right now, they are kind of had the rim-based Linac, where it has 6 bay, and it will contain all the sensitive Linac component into this and shield it for the MR. But then when you gantry rotate, it will have image artifact. And for the treatment, you really want to do it with gating treatment. So you want to real-time imaging. So when the gantry move, there will be more interference, less homogeneous field, and then there will be all the artifact. So you cannot really use those images for your gating. So right now the system, they only show you the image and do the gating when the gantry doesn't move and when the MLC doesn't move, because everything when it moves, it will interfere with the MR field and it will have image artifact. So you cannot use it for gating.
Yes, thank you for your answers.
Any other questions? I have a question about the adaptive workflow. It's obviously a very long treatment, right? The patient stays on the table for quite a long time. Has it happened that, let's say you adapt it and after an hour or so, the anatomy changed completely and then you cannot use the adaptive plan?
Yeah.
It happened? How
The worst
frequently?
case
It
I've
happened
seen.
right now. The patient needed to pee. Patient needed to pee, so we had to like start again.
Oh,
Yeah. Actually, so
Okay.
the other, I've had 2 cases of there's been a tumor, one is the lymph node, and the other's ovaries, near the bladder. So when we'd contour it,
right.
and then the 40 minutes, like the bladder would
Bladder
fill.
fills.
Yeah, and it'd be a different situation. So the first case, it changed so much. We actually put a Foley catheter in the patient and just drained it. And then that worked. And then the other one, we just tried to go fast and then found it's better if she like started with her bladder full, so it was less room to change.
So bladder is a big problem.
Exactly. That's kind of it seems like the thing that changes the most over that course of like 40 minutes to an hour.
Right. Nadia, did you have a question?
Yes, hello everyone. Thank you for this informative and interesting lecture. Can you hear me?
Yeah, we can hear you.
Yeah.
I have a few questions about the MRI Linac, and first one is I believe it is necessary to do the CT scanning, like to have an electron density to plan for planning. Is it necessary to do the CT for every patient?
That's a good question. So apparently you don't have the electron information from MR, so you need to figure out a way to get the density information. So there are different ways you can do the bulk density assignment. I know like some institute for the like GI case, if it's not close to the bone or the air, they can just override to water and it seems to be fine. So, but we feel it's definitely more accurate if you have patient-specific information. So right now we still acquire the CT image and do the fusion, then get the electron density information. It's
Can
more
you
like a
use
sample.
AI to generate synthetic CTs?
Yeah, I think that's
Mhm.
more like a research, like using AI to get synthetic CT from MR. It's more like research, but if that's,
It's not in the clinic yet.
yeah. There's some for the pelvis case and like also the brain case, but for the upper GIs might be more challenging.
Mhm.
Yeah,
Thank
the main
you.
problem,
And sorry.
just to add quickly, the main problem with MRI is that everything that isn't hydrogen, it will just see as black. So that could be air, it could be titanium, it could be tungsten, could be, mineralized bone. You just don't know. So
Mhm.
you need to be a little bit careful, right?
Mhm.
I
Okay.
see. Another one is about these uncertainties related to the influence of magnetic field. Does it taken into account in the planning system, this influence of magnetic fields in some way or not?
Yes, so the system right now uses Monte Carlo and did take into the account of the effect of magnetic field to the dose distribution.
Yeah, I saw the slide. Okay, thank you very much
For your question.
Hello, everyone. Thank you very much for your presentation, and it's very advanced treatment for the Ukraine, actually. And I have a question about the patient eligibility. And it was mentioned that mostly patients with GI tumors, lung, GU. What about head and neck cancer and brain tumors? Maybe it's reasonable, for example, for the radiation, for the better sparing of the surrounding tissues. Have you used it? And actually, I haven't seen it in literature.
A good question. So I guess starting with the brain, there is a package that I think we're going to release to try and have a magnet, because you need to put the additional kind of like magnet on the patient to image the brain better. In general, I think if I'm just like a rigid structure like the skull, so aligning to the anatomy works pretty well. But that said, if there are big changes, we do most of our imaging for CyberKnife on just kilovoltage orthogonal pairs, so we wouldn't know if it's switching. But in most cases, we think probably the skull is a good surrogate marker. For the head and neck, it has been looked at. There's been some trials for like adaptation, looking at more like fractionated treatment. I think there was one negative randomized trial. But I think any like SBRT in the head and neck, it definitely could potentially be beneficial, where you think that like soft tissue imaging could be helpful. One of our physicians here is interested in treating the larynx with it, where you could actually see if they're swallowing. Which would be interesting. Yeah.
Okay, thank you very much.
And about the tracking on the sagittal only, are you missing some information? Some of the tumors, let's say some lung tumors, can move also laterally in addition to supinf. Do you feel you're missing that information just tracking on sagittal?
Yeah,
I think
that's
probably,
yeah.
it's definitely possible. I think in the future iterations, we're looking at potentially like choosing which, like sagittal versus coronal. But yeah, it's possible that you could.
Yeah, for their new A3i system that we are supposed to get a long time ago, and it did support imaging of the sagittal, coronal, and axial plan. Yeah,
But we did not get it. Yeah.
No.
Okay. Dr. Shapil, you have a question?
No, I have not question. I have some comments about the situation. Thank you very much, Lucas and Yugao, for interesting information. I had opportunity saw what work MRIdian in your clinic in my observership. I very grateful for this opportunity. Thank you all physicists and physical medical staff for help on this beautiful, amazing observership. And I saw some case for MRIdian, then patient treat case adaptive SBRT, and it's very great job the team for physician and medical physicists, because they do adaptive treatment for all fraction. It's very hard, and and this job had good result because the treatment very exactly, and I saw the patients, his status was good for this treatment. The treatment had duration 1 hour, and it's not very long, and the patient had good condition for the finish this fraction. Thank you very much for all, and I think this information help of all of us work and do our job in our country more exactly, more increase for new level. Thank you very much.
Thank you for your comment. That's very nice. Thank you for your kind
Thank you
words.
so much. Thank you. Yeah.
Okay, if there are no other questions, we'll end this session. And our next lecture is not what was originally planned on chemotherapy, but rather on 3D printing. So next lecture on Friday is on 3D printing. See you there then. Bye-bye.
Bye, thank you.
Thank you. Goodbye.
Thank you.